As last time, we introduce you, Hamza will introduce you, and we'll go live.
Awesome.
Good morning, everyone. Welcome to TeleShadowing. We are live on YouTube. Please feel free to ask questions in the chat box as we go along and they'll be addressed. I'm honored to introduce our mentor for today, Dr. Gogu. Dr. Sajan Gogu is an osteopathic physician, triple board certified in family medicine, sports medicine, and pain medicine. He works in the South Texas Health System clinics, practicing all of his disciplines in an underserved community in the Rio Grande Valley. Dr. Gogu serves on several boards and is active in physician and patient advocacy groups. He is part of the founding circles of Doctors in Politics, a political action community that encourages doctors to run for state and federal office, believing that doctors are uniquely positioned to champion the best care for patients and be a driving force to heal America's healthcare system. He completed his family medicine residency at the University of Texas Health Center in San Antonio, followed by a sports medicine fellowship at Texas A&M University in Bryan and a pain medicine fellowship at Texas Pain Institute in Fort Worth. He's a graduate from Edward via College of Osteopathic Medicine, Blacksburg, Virginia. And now it is my honor to request Dr. Gogu to begin today's session. Thank you.
Awesome. Thank you guys for having me. I'm going to share my screen right now. So I'm going to be talking about low back pain and how important it is to really be specific about it. There's several Americans in America that do have low back pain. I think 1 in 5 primary care visits is low back pain. Everyone gets some level of this at some point in their life. These are my disclosures. So the objectives we'll talk about here today is just kind of the anatomical structures that contribute to core stability. I'll kind of run through the anatomy pretty quickly, actually. We'll discuss the differential diagnoses of the patient with low back pain, discuss the role of osteopathic medical treatment and physical therapy in low back pain, identify indications for surgical referral, indications for imaging, describe the history and physical exams that would lead you to pursue an evaluation for spondyloarthropathy, and then some of the more newer and exciting treatments that are now coming out there with regenerative medicine and spinal cord stimulators. So this is a 3-column theory of Dennis. It was stated by him in 1976. And what it really says is you have an anterior column, which is your anterior 1/3 of your vertebral, anterior 2/3 of your vertebral body. You have the middle column, which is your posterior 1/3 of the vertebral body. And then you have your posterior column. And if you look at this, there's various anatomical parts that encompass each column. And typically when 2 out of the 3 are affected, that's when you have an unstable spine. That's typically when patients, have a lot of pain. So when you look at patients that have annular tears, that a lot of times encompasses both columns. When you have people that have disc herniations, that sometimes can encompass 2 columns. So it's very important to really have an understanding of this because you can understand when things are unstable. So the vertebral body, obviously has a spinous process, superior facet, transverse process, basic anatomy there. The intervertebral disc, this is where people have a lot of problems, patients do. And so when you look at this, it's composed of the nucleus pulposus, which is this gel-like substance on the inside right here. You have the annulus fibrosus, which is right outside that. And then you have very small microvessels that kind of supply the nutrients and blood supply for the disc. And the problem is there's just very poor blood supply in an intervertebral disc. And so a lot of times when these degenerate with an annular tear, herniation, so forth, they take a very long time to heal. Like typically annular tears, for example, take 18 months to heal. That's very different from when you get a cut on your skin where that heals in like 7 to 10 days. And a lot of times that's due to blood supply. And we often forget that, the areas that, don't heal very good, such as our discs, such as knee cartilage, such as shoulder, like labrums and shoulders and so forth. A lot of times it's just due to poor blood supply. And so when you think of blood supply, if you're diabetic, you're hypertensive, you have a lot of chronic medical conditions, that can affect your small blood vessels, and that really affects healing when you look at it. So the ligaments that are encompassed the spine, they're interspinous, iliolumbar, intertransverse, supraspinous, ligamentum flavum, posterior longitudinal, anterior longitudinal. And all of these ligaments really provide stability to the spine. Lumbar muscles, there's many lumbar muscles. The psoas major and the psoas minor are some of your powerful muscles in your spine. The quadratus lumborum is another muscle that encompasses your spine, your intertransversi lateralis. Your rector spinae are really muscles that really protect you from hyper extension of your spine, and they really play a significant role in good posture. And that encompasses three muscles: your spinalis, your longissimus, and your iliocostalis lumborum. And then you have your latissimus dorsi and your thoracolumbar fascia that play a role as well. Your paraspinal muscles, like I mentioned here, you have your rector spinae. They're the major group of in our spine that, like I mentioned, it encompasses those three muscles that I talked about. They attach and link your pelvis. This really provides you lumbar spine extension, but the most important thing is that it prevents a posterior shear with flexion. So it really plays a significant role in maintaining good posture. Your paraspinal muscles also encompass many very small muscles, and these really play proprioceptive roles in your spine. You have your rotators, which are short, small muscles that really are position sensors of each segment. You have your multipidae that really stabilize multiple levels. And a lot of times these get atrophied in people that have low back pain. This is probably the principal back group that really causes patients to have, subsequent degeneration that happens in our spine. Your quadratus lumborum, is a very big muscle. It plays a role as a secondary respirator, and it's also a weak lateral flexor, and it's a stabilizer as well. And so your core anatomy, this slide is very important. This is what physical therapy really oftentimes, when I refer patients, I really need them to work on this. This is the muscular corset that we have. It just doesn't encompass our abs. It includes our multipidae. It includes our diaphragm. It includes our transverse abdominis. It includes our pelvic floor, our sacrum, and so forth. Oftentimes we think of core anatomy as just our abs, but that's just absolutely not the case. Your abs, like I mentioned, this plays a role in our core anatomy. It's not everything, but that obviously includes your internal oblique, external oblique, your rectus abdominis. Your diaphragm, plays an enormous, important role, particularly in SI joint pain. Typically, when you inhale or you exhale completely, your sacrum actually flexes down. When you inhale completely, your sacrum actually goes more posterior. And so your diaphragm can play a huge role for SI joint pain. And oftentimes, dysfunction in your diaphragm can actually lead to increased compressive loads in the lumbosacral region. So your diaphragm plays a big role in breathing, and also in terms of your spine. So the SERAPE effect basically is very key in overhead athletes. And really what this is basically saying is this abdominal fascial, this thoracoabdominal muscle fascial system really is a link between everything. And this really is what enhances, athletes, particularly that use their upper extremities and their lower extremities, because it's a linked chain at the end of the day. And so generally, when you're trying to condition an athlete or, an individual, muscle anatomy is multiplanar. And so it's very important to take into account, if you have, shoulder issues, that we need to work on people's back. If you're a pitcher, we need to work on your thoracic spine in order to pitch properly. If you're a tennis player and you're trying to serve, maintaining proper back strength, but also proper abdominal strength is very important. So this whole thing is just an interconnected chain when you look at it at the end of the day. Your hip girdle, obviously your psoas major is your primary hip flexor. And really oftentimes a very tight psoas muscle, which I see very often, it leads to very compressive forces on a disc, and that provides problems with stability. So if you look at the epidemiology of back pain, I was mentioning 1 in 5 complaints in a primary care office is due to low back pain. Lifetime prevalence of people getting this is 60 to 90%. And it's the most common cause of disability in workers under the age of 45, and it affects 1/4 of the population typically. Medicare expenditures for patients with low back pain have increased dramatically. There's been large increases in spending on epidural corticosteroid injections and opioid prescriptions. And so ultimately, this has caused a huge problem because we've had an increased use of, increased use of unnecessary procedures and tests. And we really haven't had, great results with treating low back pain, unfortunately. A lot of times mechanical low back pain, 90% of it, generally resolves on its own in 4 to 6 weeks. Even with sciatica, 50% of it resolves within 6 weeks. And then 75% oftentimes resolves within 6 months. The problem is oftentimes low back pain reoccurs. At 1 year, a lot of times, almost 2/3 of patients, have a relapse in their low back pain. So the risk factors for low back pain, obviously are physical labor, core deconditioning, decreased abdominal and trunk extensor strength, suboptimal movement patterns and technique, age plays a huge role, gender, obesity, limited spine mobility, smoking, job dissatisfaction plays a huge role, depression, anxiety. And then you always look at, is there a secondary gain here? Is this a work comp type issue? Is there a lawsuit that's playing a role in this visit as well? Because sometimes that, can cause patients to psychologically have low back pain for longer than they really truly have. So this is just a question, I have here, what is persistent low back pain is relatively a common complaint after an acute injury in a motor vehicle accident. What percentage of people, report, pain, after 1 year? And this is typically, almost 33%, that 33% of the time that, this can happen. So just very important to keep that in mind. So low back pain is a symptom, it's not a diagnosis. And this is the thing that I really harp in the community is, make sure patients have a specific anatomical diagnosis when possible. The possible pain generators for patients that have low back pain, are the disc, the facet joint, the sacroiliac joint, nerves, ligaments, muscle, vertebral body, periosteum. So there's many different factors that cause pain, and these are targets as a physician that I target to try to address patients' pain. And oftentimes you think of low back pain and you think of it as just a musculoskeletal issue, but the issue is oftentimes you can have other causes that cause this. If you look at hyperparathyroidism, Paget's disease, osteoporosis, those are things that can cause metabolic causes that can cause low back pain. If you look at inflammatory causes, like spondyloarthritis, sacroiliitis, that can cause low back pain. Infection, such as paraspinal abscesses, discitis, osteomyelitis, that can cause back pain as well. And then you can have referred pain, that comes to the spine from your visceral organs, your aorta, your hip, your retroperitoneal structures, those can obviously do that. Multiple myeloma and neoplasm can do that as well. And then obviously you have structural causes, like I mentioned before, your discs, your facets, your annular tears and so forth. Those can obviously be sources of back pain. So the most important thing when you see a patient, they always harp on this, is your history is everything. Your story is everything. And oftentimes you have to ask so many questions to get the story from patients because they're not going to spoon feed it to you. And so you just got to keep asking questions, and you're kind of like an investigator when you really look at it. After you do your investigation, you really perform a physical exam that really supports, what you think might be going along with their history. And then to confirm that, use x-rays and labs and so forth. But the most important thing is the history. These are myotomes of your lower extremities. So when you do reflexes, this is typically what you're trying to do. these are dermatomes that represent your lower extremity here. These are very important, and I oftentimes ask patients this question here. So imaging in spine disorders, why don't we image everyone with spine pain? Well, one, it's a lot of money. Two, it's unnecessary radiation. And three, oftentimes, if you image everybody, there are going to be image abnormalities. The question is, are these image abnormalities causing their pain? Most findings that you image are really clinically irrelevant, and they often lead to unnecessary tests, referrals, procedures that really don't provide any benefit. And routine imaging doesn't really improve outcomes, unfortunately. And when you image, patients, especially asymptomatic subjects, you will find findings. There was a study that was done in 1990 that, was imaging a lot of asymptomatic subjects, and 36% of these patients had a herniated disc. 21% of patients had spinal stenosis. 90% of those patients had disc degeneration and disc bulge. But we got to remember, all of these patients were asymptomatic and they had these findings. That's why your physical exam plays a huge role to see, is this really causing their pain? Then there's another study that showed that prospective MRI study among patients with MRI abnormalities prior to onset of low back pain. And 84% of those patients, had improved image findings after symptoms. So you can do an MRI on a patient, and that might not correlate exactly to their pain. And so it just goes to show you how important a patient's story and physical exam is to really get to a diagnosis. And so these are like the Ottawa rules of the ankle. This study here by Chow in the American College of Physicians. And it really is a gold standard for really immediate diagnostic imaging. Immediate diagnostic imaging, the indications really are major risk factors for cancer. You suspect infection. Do you suspect signs and symptoms of CAUDA EQUINA, and severe or progressive neurological deficits? Those are important things. Otherwise, a trial of conservative therapy, should be tried first, like physical therapy, NSAIDs, etc. So I was mentioning the diagnosis of low back pain. It's very important to understand the mechanism of the injury. Was this a sport-related injury? Was this a work-related injury? Was this spontaneous? Was this traumatic? Was this gradual? Does flexion, extension, rotation really cause this pain? Do they have a prior history of low back pain? What is the location and characteristics specifically on this back pain? What is the duration and progression of this? Radiation, is there any aggravating, alleviating factors, prior injuries or surgeries, any other joint problems, any prior diagnostic tests or treatments? Is there a work comp or legal issue that's causing this? I think this is very important that you get a good history on your patient, so you get a good story. Red flags, like I talked to you guys about earlier, infection, tumor, fracture, CAUDA EQUINA, those are, things that are very important. CAUDA EQUINA is one of the most important things that you pick up because if you don't pick this up, you can really cause permanent nerve damage for the patient. And this is where you have a major central prolapse of a lumbar disc that really compresses the nerve roots within the spinal canal. And these patients lose bowel, bladder, they can't walk, they're wheelchair bound. And so it's amazing once you see one of these patients and you do surgery on them immediately, their symptoms are dramatically improved ASAP. So red flags, how do you get to a red flag on a patient? Obviously age greater than 50 can be a red flag. These patients are higher risk for osteoporosis. And so that can cause pain. People less than 20 years old, that's kind of unique, for those types of patients to have red flag symptoms. And then obviously history of cancer, unexplained weight loss, recent fever or chills can be a cause, immune suppression from taking steroids, being HIV positive, recent bacterial infections, IV drug use. These are all red flags that you have to suspect, there should be something else that's probably causing this low back pain. Red flags for fracture, compression fractures are very common. They're particularly common in the osteoporotic population. A lot of times these people fall down and they get a fracture. There's an image here that showcases that very clearly. These are really people that have age greater than 70 years old, and oftentimes their movement pattern is that they have pain in extension. Red flags for CAUDA equina, like I was mentioning, bladder dysfunction, retention of urine, increased frequency or overflow incontinence. They lose anal sphincter tone, or fecal incontinence is there as well. They have saddle anesthesia, so they have a lot of numbness in their groin area, and they have progressive motor weakness in their lower extremities and foot drop. Mechanical low back pain, like I was mentioning, it's pain that's increased with mechanical stress. It's pain in the low back pain, frequently radiates down the buttocks, it's occasionally to the posterior lateral thighs. Oftentimes the etiology is uncertain with mechanical low back pain. Sometimes, 85% of the time you really can't find specific anatomical diagnosis. But the good thing to note is usually 90% of these patients, they recover in 4 weeks very easily. And so this is a prime example of a patient with mechanical axial low back pain, right? 38-year-old male that has acute onset of midline low back pain while playing touch football with kids. The pain is an 8 out of 10, radiates down the left buttock and hip. Pain is increased with sitting, improved with laying down. Coughing causes severe 10 out of 10 pain. There's really no red flag symptoms right here. And the physical exam, when you do it, the patient prefers to stand in the exam room and walk around. They don't like to sit down. But your entire exam is really normal. Strength and reflexes are normal. They really just have pain on range of motion, and they have tenderness in their low back area. There's not really any type of, severe red flag symptoms that are here. So this is oftentimes what mechanical axial low back pain presents like. The treatment for this is relative rest, education, reassurance. Heat and ice is helpful. Physical therapy, involving core stability is very important. OMT is very important for this as well, as most studies indicate that, OMT really provides short-term benefits and doesn't have any side effects. But this is the type of case where you don't want to get to a point where you're doing too much. You don't want to do injections on these patients. You don't really want to do surgery on these patients. Conservative therapy oftentimes is very vital for mechanical axial low back pain. So mechanical axial low back pain on X-ray, it typically looks very normal like this. Typically, you don't see any findings in their discs. You don't see any foraminal stenosis that's here. Alignment of all the discs is proper. You don't see any severe degenerative disc disease. You don't see any spondyloarthropathies that are forming. This is what you typically see in mechanical axial low back pain. Their MRIs typically are pretty normal. You can see here there's a disc protrusion at L4, L5, L5S1, but this doesn't, mean that this patient needs an epidural. If you look in the axial view, you don't even see those nerve roots being compressed completely. So the most important pearls on mechanical axial low back pain is you want to consider differential, and you want to assess for red flags. You want to reassure, keep the patient active, empower the patients with tools to self-manage the pain. Obviously, short course of manual and manipulative therapy is very important. Keep the patients working and limit the use of controlled substances at the end of the day. OMT is super helpful. There's studies that have shown this, including in the New England Journal of Medicine, that shows how using osteopathic manipulation is very helpful. This study here, particularly done in 1990, really gave the osteopathic profession wide exposure and really just showcased the efficacy of OMT to the entire world. There's this book here that's done that's called Evidence-Based Manual Medicine, which is written by Kuchera, who's one of the probably the godfathers of OMT. And it really just shows, all these things that's written here in terms of how much benefit patients can get. You can get decreased pain, decrease the need of physical therapy, decrease the use of medication, compared to the other group that didn't get OMT. So just showcases how OMT is very vital, particularly those individuals that are considering going to osteopathic medical school. It's a great education because you have a tool in your kit that, the allopathic physicians do not. And OMT, I'm not going to go through this in detail, but there's many different techniques, direct techniques, indirect techniques, combined techniques. I'm going to skip on this part because it's pretty complex and I really can't do a fair job of teaching this in 60 minutes, but I'm just going to run through these slides here. But this is typically how it looks, OMT, and to kind of how you go about treating it and going about how you position patients. But I'm going to skip these slides here, but you can get the gist of kind of what OMT is. OMT is very different from chiropractors and what they do, because chiropractors, you know, oftentimes don't have a specific diagnosis. They go directly into treatment. You know, osteopathic medical physicians oftentimes have a diagnosis, particularly that, you know, is causing them the problem that is identified as a problem that they go attack. So that's really different. The McKinsey method is something that's very vital for physical therapists to help them with pain. Really what the McKinsey method is trying to do is trying to centralize the pain to one area instead of a multitude of areas, and trying to target it once they isolate the pain to one specific area. And this kind of, you know, showcases some of the things that, you know, physical therapists try to do to help patients with low back pain. The SI joint is a big cause of low back pain. I see a lot of this in my clinic. I do some of these injections done under ultrasound, as you see in this picture on the bottom right. And typically it's just pain right in the SI joint. You know, you palpate right there, you get pain, you do different provocative maneuvers for that. And there's many types of ways you can treat SI joint pain. You can do SI joint injections. You can block the nerves that innervate the SI joint. You can burn the nerves that innervate the SI joint. So there's many different things. Imaging is really not helpful for this. This is really typically clinical diagnosis. And this is how I typically do my ultrasound guided, you know, SI joint injections, getting medicine right in the SI joint. So there's spondylolysis and spondylolisthesis. Very important to know these two. Spondylolysis is really where you have a defect in your pars area, and that's really in the Scotty dog, the neck. And typically, you know, when you get spondylolysis, typically in years down the road, you will get spondylolisthesis, because that typically the facet joint is really what helps prevent translation of your vertebral body. And oftentimes to discern whether someone has spondylolysis, you know, you have to do an x-ray, but you don't see it often on there. So you really need to go to an MRI. And spondylolisthesis, it's really helpful to actually do an x-ray, but make sure you flex and extend your patients, because then you can see translation. And so you can see the utility of flexion and extension, you know, in x-rays, because you can see this patient here is in normal position. Their L5-S1 is completely aligned. And then you put them in extension, or in extension, and then you see the spine shift completely. You can see how there's almost a centimeter of a shift here. And then you put them back in extension, and then you see the shift that you see back this way. So flexion and extension is vital because it can tell you about instability in an individual spine. Spondylolysis, like I mentioned, MRI is kind of the gold standard in determining a stress reaction there. A CT can also help. It gives you greater sensitivity towards bone. It really is helpful in seeing if that pars fracture is healing. Ultimately, if you're trying to determine if it's a bony abnormality, you use CT. If you're trying to determine if it's soft tissue inflammatory in nature, you use an MRI. So the treatment for spondylolysis or spondylolisthesis is really relative rest. You want to avoid back extension as much as possible. Physical therapy is vital. Bracing is helpful. I'm not a huge bracer of people unless it's vital. The reason I don't like to brace people with low back pain is that they subsequently develop weakness in their muscles in their lower back area because they're dependent on the brace, and that can cause further problems down the road. If spondylolisthesis is grade 2, like this picture, I typically send them to surgery. But prior to that, I typically do an epidural or so in their back to see if that can provide some level of relief for the patient. But also an epidural is really diagnostic and therapeutic for the neurosurgeon when I do it. Radiculopathy is irritation of the nerve root, most commonly caused by disc protrusion. Oftentimes we call this sciatica in the layman's terms, and that's what people say, but really the true term should be radiculopathy. And oftentimes this affects the lower back area. L5 and S1 are primarily the ones that are affected. And classically, patients have leg pain worse than back pain. Coughing, sneezing is really debilitating for these patients. And these patients, have a positive straight leg raise test when you do your physical exam. So typical signs and symptoms of lumbar radiculopathy, you have a 42-year-old runner with abrupt onset of right-sided back, hip, and thigh pain. And they have numbness that's going down their anterior thigh, weakness down their leg. They have a hard time standing and sitting. Their physical exam, shows normal reflexes, but they have usually often either a positive straight leg raise or a positive reverse straight leg raise. In this case, it was a positive reverse straight leg raise, which tells me it's probably, L2, L3, or L3, L4 potentially that's causing that, because that helps. The reverse straight leg raise is most helpful in helping you with upper lumbar dysfunction versus straight leg raise simply is for lower lumbar dysfunction. And then oftentimes you see weakness because the nerve is being affected. This is the normal MRI of a lumbar spine here. This is what a herniated disc looks like. As you can see, the disc is completely occluding the nerve. Oftentimes on these patients, if they have decent motor function, I'll do a transforaminal epidural to see if it'll help them. If it does help them, that's diagnostic and therapeutic for the surgeon to go in and do possibly a discectomy, on this case. So lumbar radiculopathy, the relative treatment is rest, education, medications, including oral steroids are important. Heat or ice is helpful. Physical therapy, there's some evidence that shows that traction inversion table is helpful. OMT is super helpful as well. Epidural injections and selective nerve root blocks are really effective very early on in a patient with radiculopathy. I typically do this in a surgical center with a C-arm, and I target my needle exactly where the nerve root is. And then surgery is often the case if all your conservative measures, including epidural injections, don't work and patient still has refractory symptoms. This is a caudal epidural. This is something that I do under ultrasound. And so basically I'm sticking a Quincke needle in the spinal canal, but through the tailbone, and medicine comes through their spine. And so typically I mix dexamethasone with preservative-free normal saline, and this can help with L4, L5, L5S1 type of lumbar pain. But this is something that's very helpful that you can do in your office setting. Lumbar radiculopathy, it's very careful that you assess and document your neurologic exam, because that often tells you which level the problem is at. You don't want to forget to assess the lumbar nerve roots here. And so the reverse straight leg raise is very helpful. You also want to, do early imaging when possible on these patients, especially when there's neurological deficits present, because you don't want that neurological deficit to progress. And then prompt neurologic deficit should really prompt a surgical referral as soon as possible. Spinal canal stenosis is a narrowing of the spinal canal that can be degenerative or congenital or both. This typically happens in the elderly population. This happens when this is a case where a 68-year-old female who's an active walker with a 2-year history of pain in the back and legs, is having pain. Oftentimes their pain is episodic, but sometimes their pain is progressive. And typically with spinal canal stenosis, these patients walk as if they're pushing a grocery cart, and they walk lean forward. And they really have heaviness in their legs. The exams typically on these patients, oftentimes, they show that their straight leg raise is negative. They really have proximal weakness in their thighs. They have reduced reflexes in their legs. It's very important to feel their pedal pulses, because sometimes spinal canal stenosis can really confuse you with a vascular insufficiency, because these patients have such heaviness in their legs The problem is patients with heaviness in their legs, vascular insufficiency can be a cause. So you really need to examine their cardiovascular system as well when you suspect spinal canal stenosis. This is imaging here of an individual with spinal canal stenosis, and you can see the narrowing of the spinal canal on this image on the bottom right, particularly at the arrow. Then there's also neurogenic spinal canal, spinal stenosis, and this is where these patients have claudication type symptoms, and this is where their leg pain is greater than their back pain. And like I was mentioning, these patients have to flex forward, but on vascular claudication, these patients typically are better at rest. And so, you know, if you're having pain and you keep on moving and you're leaning forward, you know, you're exerting yourself. And those patients, typically when you exert yourself and have lower extremity weakness, that's a vascular cause. It's not a neurogenic spinal canal stenosis. So it's a very big differentiating factor when you're trying to get a history. And ultimately, that's why your history is so important, because you have to ask them these questions to get that answer. Physical therapy is helpful with patients with spinal canal stenosis. Medications helpful. Epidural steroid injections are helpful. And typically these patients need, you know, surgery to decompress their spinal canal to get the relief that they need. So with spinal stenosis, you know, these are patients with pain with standing and walking, relieved with sitting. Neurologic exam may be normal. And it's very important, like I mentioned, that you differentiate from vascular claudication. CT or MRI may show central or foraminal stenosis. Facet pain may mimic stenosis. And you obviously, with spinal stenosis, you never treat an MRI, you treat a patient. That's one thing I obviously teach my medical students and residents that rotate with me is, you never treat an image, you never treat a lab, you always treat a patient. So don't go, you know, doing things just because an MRI shows something. Talk to your patients, see if they're actually suffering from that, if that correlates with your MRI. There's rheumatological causes of low back pain as well. I'll briefly go through this. Ankylosing spondylitis, it's probably one of the most common causes of this. It's 5% of the population of young low back pain. And these are patients that really oftentimes have low back pain that lasts for a multitude of months, 3 months or so. And patients for this are typically start with their pain at younger than age 45. But the fortunate thing is exercise helps these patients. And there's the association of morning stiffness with rheumatological concerns typically. Spondyloarthritis or spondyloarthropathies, you know, they're very difficult to diagnose. Oftentimes you see x-ray findings on these patients 10 years after the fact and when this started. And typically this is missed. You know, we as physicians miss this because, you know, the changes, if we do see it on an image, we see it often 10 years after the fact. So this is just very difficult to diagnose. And there's oftentimes no physical exam findings with these patients, you know, they just have generalized low back pain. So it's just important to keep this in the back of your mind that it possibly could be this. But like I said, it's very difficult to pick up on, unfortunately. Lumbar spine fractures, you know, these are fractures that can be very debilitating. Burst fractures, this is a burst fracture that's right here. And these patients, you know, if they're stable, you know, if it's affecting, you know, only one column, then, you know, you can obviously just do a lumbar brace. But if it's unstable, you know, these need surgery. Compression fractures, you know, often if they're stable, bracing is fine. But if they're unstable, where they have 40% loss of vertebral body or body loss or greater than 25% of vertebral body height, those are unstable, and those typically need a kyphoplasty. So these are different braces we have. And like, you know, I have a question here of like, what is the most common appropriate brace for compression fracture? And the most common cause for the best brace is actually choice D, and that's a Jewett back brace. Oftentimes we see on the market, you know, B and C, but these types of back braces are more for comfort measures. The Boston brace in A is for scoliosis. So there's a lot of newer emerging therapies that are coming out in the market. You know, it's exciting time in medicine. You know, we have PRP and, you know, amnion and lipogems and so many other regenerative medicine tools that are there to help with healing. And so this is a new tool that a lot of clinics, particularly in sports medicine and even pain management, they're using PRP to help people with pain, and it's been very beneficial. There's also neuromodulation, such as a spinal cord stimulator. This is where we put leads in an individual spine, and then we put a device that puts a different frequency of current in the lumbar spine that really helps people with pain. It's typically common in patients that have failed back syndrome, but it can be used for CRPS, or complex regional pain syndrome, lower extremity peripheral vascular disease, intractable angina, and so forth. So it's just something to keep in mind. This is going to get, even in the upcoming years, neuromodulation is going to get very advanced. There's several mechanisms of action of spinal cord stimulators. I'm not really going to go into that in detail. These are my references that are here. This is my email. That's my cell phone. If you have any questions, feel free to text me. That's my email. If you have any questions, feel free to email me. But that's pretty much my presentation here today.
Thanks so much, Dr. Gogu. We'll now begin our Q&A session. Let me just pull up our questions now. 1 second.
Thank you for your mentorship and teaching, Dr. Gogu. We will begin our Q&A session.
Awesome, no worries.
Yeah. So to start off our Q&A, is there an increase in the incidence or prevalence of lower back pain due to the reduced back posture quality, especially in the rise of the usage of our cell phones or couch sitting?
Yeah, that plays a role in that. I mean, like I mentioned earlier, our rotaries, our multifidi, those are muscles that play a role with proprioception and mobility. And we're becoming less active, and those muscles are atrophying. And when you atrophy those muscles, you have poor posture, and that subsequently causes disc issues and back problems over time. So absolutely, it plays a huge role.
Right. Thank you for that answer. Does having a strong core help prevent low back pain?
Yes, absolutely. Like I mentioned, strengthening those muscles, such as your diaphragm, your thoracoabdominal fascia, your rotaries, your multifidi, your abdominal muscles, your pelvic girdle, like those all play a role in maintaining, a strong and healthy back. So absolutely it does.
All right. So you just stated right now that having a strong core helps with back pain. So does it run in families or not? Because what you implied was that if you're healthy with your core, it would prevent back pain.
Yeah, so does this run in families? So no, absolutely not. Like a strong core is something we acquire, we work on, we build. And so that is not something that's just, handed to you. If we are eating unhealthy, if we are exercising very poorly, if we are living a very busy life, if we have so many chronic medical conditions that we're unfortunately not able to take care of, that all can play a role in you having low back pain. So it's not familial in nature. A lot of this is acquired.
All right, thank you very much. Now, is lumbar back surgery an option for patients with osteoarthritis?
Not simply for just osteoarthritis. Typically, lumbar spine surgery is relegated to people that have motor weakness, or that have such poor quality of life from the pain that they're experiencing. But oftentimes there's a neurological deficit, like they have decreased reflexes, they have weakness that's down the leg, they have intractable back pain, and so forth. So for simply osteoarthritis, no, it's not an option.
Is there any way to tell that lower back pain is something more serious? So if it could be a symptom of some major disease or whatnot.
Yeah, absolutely. It can be. That's why on one of the slides I was mentioning, there's different causes of low back pain, like metabolic, like neoplastic, like rheumatologic, And so if you try to do your exam and your history and you discern that there's nothing on your imaging that's really, suggesting this, or your history is leading you a different way, it's something that's very important to keep in the back of your mind, that maybe this is not a musculoskeletal cause of your low back pain.
Okay, thank you. This is coming from somebody that's headed for DO school. Is OMT a safer option for patients' nerves than chiropractic care? And have you used OMT before with success?
Yeah, I've used OMT before, primarily with patients that have cervical dystonia or cervical spine spasms, or their lumbar spine is spastic, or they have poor alignment. I've used it, to help patients restore posture and restore some semblance of normal motion. The way I do it is you typically try to find a diagnosis, because structure and function is interconnected. Chiropractic care is not so much predicated on that theory. And so I feel OMT is much more safer than chiropractic care. Oftentimes manipulation shouldn't be the first thing that's used, particularly if you have dysfunction.
Thank you very much. And for our final question, what are the best non-surgical treatments for lower back pain?
The best non-surgical treatments, I would say, is definitely, NSAIDs, Tylenol, physical therapy, and physical therapy is obviously very important. I think, taking care of your chronic medical conditions, if you have any, or preventing them, is very vital. Like one of my earlier slides I mentioned, your discs is dependent on good blood supply, and chronic medical conditions affect healing. So it's very important to have good health. Obviously, staying active is very vital. Good psychological health is very important. A big cause of, patients having low back pain is work or psychological, or depression or anxiety. So mental health plays a huge role in that. And then ultimately, if you have all of that that's kind of taken care of or not addressed, that's when you go to interventions like epidural injections, transfemoral ESIs, regenerative medicine, spinal cord stims, peripheral nerve stims, before then you go into surgery.
Thank you, Dr. Gogu. These are all the questions we have for today. We really appreciate you taking the time to mentor us today. I'd love everyone to please give a warm thank you to Dr. Gogu in the chat box for this incredibly informative session.
Thank you so much for having me, guys. You guys have a good weekend.
Thank you so much. Now we're going to conduct our closing session with our quiz and future session dates. So the link to the quiz for this session is now live. You'll need a 70% or higher, as always, to pass and receive certification. And the link to the quiz is being sent in the chat now. And now on to our next session dates, which will also be posted throughout our social media outlets, so be sure to follow us at TeleShadowing. Our next session will be next Saturday, November 5th at 10 a.m. Eastern Standard Time with our physician mentoring us in psychiatry. Thank you so much, everyone, for attending today's session, and we hope to see you in upcoming sessions as well. This concludes this week's shadowing. Thank you.